So some people think harm reduction means condoning drug use. They might ask, why would I give you a clean needle when, frankly, I don't think you should shoot up drugs at all? Or they might think that giving a naloxone kit is actually a permission slip to overuse or to put themselves in a risky situation. So what do you say to people who think like this?
I think that my job or our job as treatment providers isn't to police other people's what people do and do not do, but my job is to reduce the suffering, reduce the impact that it might have for them, and harm reduction is a strategy to do just that. It's to meet the person where they are. If a patient comes in and says they are going to use heroin IV, then how can I help them mitigate the risks that are involved with that? How can I help them understand what the risks are, mitigate those risks to themselves and to other people around them? That seems to be my ethical duty.
Would we ever tell a patient with a bee sting allergy, don't go outside, right? We would, of course, arm them with something that could reduce their risk if they come in contact with a bee, right? We'll give them an EpiPen before they walk out the door.
That's a great analogy.
It just seems, it is what we do. Our whole goals as providers in the healthcare system is to keep people safe and healthy through assessment, evaluation, education, and treatment, right? And so harm reduction is part of that, and we do it all the time. I mean, the bee sting analogy is a extreme one, but we do it when we're talking to patients about self-management of diabetes and hypertension and depressive symptoms. We talk to them about managing their symptoms and keeping them safe, and that's what harm reduction is.
Almost all chronic conditions are treated in a harm reduction kind of model. Mm-hmm. We try to reduce risk as much as possible, and if we don't get the blood pressure perfect, it doesn't mean we're going to stop treatment.
Right.
We continue to think about other alternatives, et cetera.
I think that speaks in part to the judgment that is often a part of substance use disorders, or the criticism of it, so the stigma attached, that the provider, whomever is sort of uncomfortable with harm reduction, there would have to be the question of why are they uncomfortable with this? Is it a criticism of substance use in general or of the individual, and a discomfort with the person continuing to do something that they don't support them doing, so not being comfortable with the other person being autonomous and choosing for themselves what they'll do. So the clinician's loss of control. I mean, they're not in control in this situation, which is uncomfortable often. So it's not just for the patient, loss of control in terms of how we talk about the substance use disorder, but whomever is involved in it, sort of not being able to control what the individual is doing.
I've had fellows say to me, I can't believe they did this to me. Their urine has opiates in it, and I'm treating them with buprenorphine. They didn't do anything to you. And I think that really gets at that control thing. And back to an earlier point you made about, if you know what the patient's goals are from the beginning, and although they may be very different from your goals, you can always come back to that, right? You can always come back to if you have functional goal setting with the patient throughout treatment and reassess those along the way, patient's goal may not be absolute abstinence. It may be reducing their harm from risk, and that's where using some of the techniques that we've talked about in this course to really organize the information when we're doing assessments and evaluations. We know we're on the same page with the patients about our concerns of risk, and it may not align with their goals, but we can bring that back as we're talking about their goals. I'm sorry I interrupted you.
No, that's okay. I mean, I've been involved with harm reduction for 30 years, or almost 30 years, and I'm growing increasingly unfond of the term, only because it seems our conversation so far has been all about all of the negatives about the risk. But I think our job really is to improve people's quality of life. And therefore, any positive change that we can help a patient or an individual who's not even necessarily a patient make at any given time should be considered an improvement. Now, maybe the physician who it feels betrayed because a patient is on buprenorphine and has it, and also is taking an opiate on top of that, that might be true, but maybe he should realize that what he has done by giving him the buprenorphine is probably reduce the likelihood that he's going to be using as much opiates and reduce the likelihood that he's going to die of an overdose. Or the likelihood that he's going to become infected with hepatitis C or HIV. So we have to think of this as a positive and not just think about, harm reduction is prevention. It is not necessarily primary prevention of drug use, but it is certainly prevention of avoidable medical and social sequelae that can be catastrophic. And, I want to continue to do this work because, it's very gratifying when it does work. And even when it doesn't work, you at least realize that you're doing something that has the potential to do something. It's not all or nothing. It is very much on a scale.
I have a colleague who has been trying to reframe the term harm reduction to optimizing safety rather than calling it harm reduction in that same vein.
I like that.
I'm really glad you said that. Optimizing safety.